Good evening, everyone. Welcome back to our Life in Motion monthly webinar series. I'm Caitlin, and tonight we have with us back again Dr. Lee-Sigler. She graduated cum laude from Lewis University in Romeoville, Illinois, where she was in the Air Force ROTC and was commissioned as an Air Force officer shortly after graduation. She received her medical degree from Temple University School of Medicine. She served 6 years reserve duty and 4 years active duty in the United States Air Force, where she served as the emergency room practitioner. Dr. Lee-Sigler went on to complete a residency program in physical medicine and rehabilitation and was chief resident her last year. After moving to Champaign, Illinois, she served as a clinical instructor at the University of Illinois College of Medicine, was attending staff at Carle Foundation Hospital, and served as medical director of the Inpatient Rehabilitation Unit, Therapy Services, and the Carle Spine Institute, while serving as a division head of physical medicine and rehabilitation. After arriving in the Memphis area, she became an owner of the Memphis Spine Center and later joined OrthoSouth. This evening, Dr. Lee-Sigler will be breaking down the key differences between males and females regarding spine health and helping us understand gender-specific conditions and treatments. Like last month, we're changing things up a bit, so throughout the webinar, Dr. Lee-Sigler will be asking you some questions. And when she does, feel free to drop your answers in the comments. It's totally okay if they're wrong or if you have no idea, still guess. And after a few moments, she'll reveal the correct answer. And as always, feel free to submit your questions in the comments throughout the webinar for Dr. Sigler to answer. I'll let you kind of take it from here.
All right, thank you for having me today. Today we're going to talk about some gender-specific conditions related to spine health and how we can address them and things to look out for. So I'm going to start out with a little fun quiz question, and that is, if you look at this picture, the skeleton, is this a skeleton of a male or a female? I'm going to give you a little time to answer that.
Yeah, so submit those in the comments, and we'll read some of those out. I did cut off the hair, so they couldn't cheat with the hair. All right, so I've got Miss Linda says female, Miss Andrea says male, Miss Crystal says female. We've got male, male, female. Give one more person, female. So, you want to reveal the answer?
Yes, let's reveal the answer. It's a male. All righty. So let's put those two together, and you can see some of the differences between male and female skeleton. So women have wider pelvis, kind of that heart shape, relatively narrow shoulders, relatively short legs. And in addition to that, there's some other differences outside of the skeletal system, and we'll talk a little bit about those. Less muscle mass overall. So overall, women are about 30 to 35% muscle weight, while men are about 40 to 45% muscle weight in general. There's also differences in the types of muscle fibers that men and women have and how we activate them and at what times. There's differences in fat type and distribution. So women have more what's called subcutaneous fat, or fat that's just kind of under the skin. And then men have more visceral fat, which is fat that surrounds the organs. There's also biomechanical issues that are different. And one of those, I just chose a couple of things, and one was golf. Women have a much greater range of motion in their torso, their pelvic rotation, and their shoulder rotation at the top of the backswing. They have a narrower stance, and they have different hip and knee, the way they bend and the flexion patterns. And then for golf, and then for tennis, for instance, women, they use their lower bodies a lot more. So we use our lower bodies, and men rely a whole lot more on their shoulders. So you're going to see different types of injuries oftentimes in men and women with these sports. And then going on to hormonal issues, and I separate these based on a few things. So the anatomic issues, some of the biomechanical issues, hormonal issues. Mm-hmm. So for hormonal issues, high estrogen levels, those increase muscle mass and strength. But at the same time, you're going to have differences in the tendon length. And so tendons connect muscle to bone, ligaments connect bone to bone. Those tend to be a little bit more lax or pliable as a result of the estrogen levels. Pregnancy, rising levels of estrogen and progesterone, That helps with the connective tissue compliance, so you can be more stretchy to deliver the baby. But that's assumed to lead to an increased risk and injury. So you see more ankle sprains, those sorts of things. The other thing that can happen is there's joints that connect the back to the hip called the sacroiliac joint. Those have to get more lax, those ligaments get more lax in order to deliver the baby. Well, sometimes when that happens, there's more fluid that develops in one joint than the other joint, and that can lead to pain and problems. So those are some of the issues. There's lots more, but those can occur during pregnancy because of the estrogen and progesterone levels. And then there's postmenopausal hormonal issues. So at this point, you had your higher muscle mass, and now you're having less muscle mass, and also less bone density typically. And then there's been a recent link of estrogen loss to osteoarthritis. And so women will tend then to get more osteoarthritis. The other thing I wanted to mention going back to pregnancy is, when women are pregnant, the overall mass increases, right? But the muscle mass doesn't increase. So you're carrying more with less relative muscle. So that turns out to be important. And then there's what I call some overlapping issues. So that would be things like pelvic floor dysfunction and pelvic pain. So those are two separate conditions. So pelvic floor dysfunction can be caused by a number of things, and so can pelvic pain, and sometimes they occur together. Oftentimes the causes of pelvic floor dysfunction can include traumatic injuries, so motor vehicle accident, fall, overusing the pelvic muscles, so straining, prior pelvic surgery, hysterectomies, pregnancy and childbirth, especially difficult deliveries, large baby or otherwise kind of mismatch between the pelvic size and the baby. Aging, because muscles will naturally weaken during that time. And then connective tissue disorders. We already talked a little bit about sacroiliitis, and then hip fractures. And that can occur for a number of reasons.
That's for both male and female?
For both male and female, but women tend to have, because of reasons we'll talk about later, higher incidence of sacroiliitis and a higher incidence of hip fractures. Some of that's related to hormones.
Yes.
And it occurs at different times.
Gotcha.
Yeah. There's also immune system differences. And there are higher incidence of autoimmune disorders in women than men. So those are things like lupus, rheumatoid arthritis, those sorts of things. Not all of them, but most of them. Alrighty, there's another question coming up.
Yeah, so get ready to drop your questions in the chat, or your answers to the question in the chat. And like I said before, if you are wrong, that's totally okay. But we want to get you guessing. So who has more adverse drug reactions, male or female? So which ones have more instances when they're reacting to drugs? Let's see what people say. My guess when I first looked at this it would be pretty even between the two, but I was surprised. All right, so Miss Linda says female. We've got Eileen who says female. Charlene who says male. We've got female, 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 female. I feel like the title of this webinar gives it away a little bit.
All right, so the answer is female, but now by what ratio do you think? So take a guess in terms of what you think, like 2 to 1, 3, 4, 5, 6 to 1. What do you think?
All right, let's see. My vote would probably be, I don't know. I would say like 3 to 1 before I saw this. Okay. Just from working in the clinic. And Andrea says the same thing. Chanel says 3 to 1. Okay. Miriam says 3 to 1. Okay. Eileen says 4 to 1. 3 to 1. Okay. All right.
All right. So the answer is 2 to 1. So about twice as many adverse drug, and this is across all drug classes, every drug class.
Can you explain what that is exactly?
That means, so not necessarily an allergy, but a reaction that is not good. So a bad reaction. So that could be that something that maybe shouldn't make you sleepy makes you sleepy. You get itchy, but it's not like a full blown allergic reaction. You get odd thoughts with a medicine. Yeah, those types of things,
Gotcha.
or an exaggerated reaction of some kind.
Gotcha. Okay. All right. So I'm going to be asking you, Dr. Sigler, these questions. Is osteoarthritis more common in women or men?
All right, it's more common in women. Now, this is a little bit interesting. So, up until menopause, the ratio is 1-to-1 for osteoarthritis, women to men. After menopause, it's 2-to-1 female to male in every joint except the shoulder and elbow. So, shoulder and elbow, the guys have it, or it's more even, but every place else it's 2-to-1 women to men. And then that goes back to the recent information with regard to how estrogen affects joints.
All right. Is low back pain in general more common in women or men?
Yeah. More common in women.
That's surprising.
Yeah.
I'm learning so much.
Yeah. So a lot of times you think, men do a lot of heavy lifting, that sort of thing. But interestingly, women do a lot of lifting as well, from children to, things around the house that they shouldn't, to repetitive lifting. And, many people, many women these days are working warehouse, but also a big risk for back pain is jobs that are sedentary, where you're sitting for long periods of time at a time. So that those are all factors.
Gotcha. All right. Let's see. Next question. Let's see. There we go. Is neck pain in general more common in women or men?
Yeah. Neck pain is more common in women. Yeah. Our joints are smaller. Body mechanics are different. And many times, how we lift and how we hold ourselves when we're sitting to work on computers, that sort of thing, is different. And also the way that chairs are made for tables and desks are not always ergonomically correct. And so that will oftentimes affect people who are either shorter than usual, smaller than usual, or also taller and bigger than usual. So that's kind of where sometimes guys will come into it, but a lot of times it's that plays a factor in why women have neck pain.
So we have it for osteoarthritis. We win.
Yes.
Not in a good way.
Yes.
For neck, for low back. And the next question is scoliosis, the abnormal curvature of the spine, more common in women or men?
Yeah, it's more common in women as well. So if we look at the National Institute of Health, their data says that for females it's 7-to-1 female to men, and for the American Academy of Orthopedic of the Orthopedic Society is 10-to-1. Oh, so wow. American Academy of Orthopedics 10-to-1, and 7-to-1. So we know it's at least somewhere in there, and we think that some of that has to do with hormones as well.
Gotcha.
Yeah. And there are other factors. It's really multifactorial.
Gotcha.
Yeah.
All right, so moving past that into musculoskeletal disorders, this is what you see every day, day in and day out. So I'll kind of turn it over to you of some common ones that affect us more so than men.
Okay, so we talked about osteoarthritis, osteopenia meaning thinning bones, and osteoporosis, rheumatoid arthritis, and many of the autoimmune disorders. We talked about low back pain, neck pain, scoliosis, and also hypermobility spectrum disorder. So those are things from Ehlers-Danlos to a variety of other connective tissue disorders that involve hypermobility. And those have a variety of musculoskeletal symptoms as well as autonomic systems, meaning those that regulate your heart, regulate whether or not you have headaches, dizziness, those sorts of things. Stress fractures, more common in women. Again, osteopenia, osteoporosis. And just in general, I thought some things that were interesting were ankle sprains. And again, that's, again, it kind of comes down to the compliance or how stretchy the tissue is. And, even though men have more, there's a ligament called the ACL, it's a knee ligament, and even though men have more of those injuries, women are more prone to those injuries just because of our anatomy. And then a certain type of hip impingement syndrome is more common in women than men, or a higher incidence. Yeah.
Gotcha. All right, so we've talked a lot of negative things that affect us as women, but wanting to kind of, this next slide is a picture, a graph of the gray scales showing more instances in research done versus the male.
Mm-hmm.
But with this kind of statistics, what can we do?
Yeah. So there are some things that we can do, and I think being proactive is going to always be the answer. And a lot of these things are low-tech things, and they're things that you probably, some of them you've learned, from childhood, but we tend not to do in our busy lives. So the first thing, optimize your diet. Mm-hmm. You need, so an anti-inflammatory diet, or a diet that's just more healthy. There's a lot of fast food, a lot of fried food. All of those things are high in inflammagens. Processed foods, especially ultra-processed foods, those are not good in terms of keeping the inflammatory cells down, mm-hmm. In your diet or in your body. Optimizing vitamin D, and that's something that can be done as a standard blood test and should be done. But I learned even today, a woman in her early 60s hadn't had a vitamin D level in 5 years, despite wow. Going to her yearly physicals, etc. So that is something that is a standard blood panel can be asked for if it's not, and that can help a lot too. Maintaining appropriate weight goes back a little bit to the diet, and there are a lot of scales that we use for whether or not a weight is appropriate. There's some controversy about that, but I think in general, there's a range that is considered appropriate for a person of a certain height and body build, and I think maintaining that is good, and also maintaining good muscle. So having a balance in terms of your exercise, working with your primary care doctor, your OBGYN, endocrinologist as appropriate, physical therapy or trainer to optimize your bone density, your hormonal balance. Weigh the benefits or risks of estrogen based on a lot of factors, including your family history, cancer history, etc. So those can be a little bit tricky, but at least addressing them turns out to be important. Your fat to muscle ratio, that's what I was talking about a little bit with appropriate, weight. So sometimes people have what seems to be a weight that's appropriate, but they don't have a lot of muscle mass. Strength and mobility, and this is important too. There's a difference between stretching and mobility. So when you're doing a mobility program, you're using the joints and the muscles to move through a range versus stretching where you're just moving tissue without using balance and muscle strength, et cetera, to do that. So there's some very good mobility programs in addition to stretching programs that can be really helpful. Try to address spine and other musculoskeletal concerns before they become disabling. I was talking to a urogynecologist about this, particularly related to pelvic floor dysfunction. And one of the things we talked about is that particularly for women in pregnancy, and particularly with multiple births, that sort of thing, it's really a good idea to meet with a therapist or pelvic floor therapist to do some things preemptively. So that you don't run into trouble later on, or at least you can control that and already be, involved in it. Be consistent in your efforts, and then realize that scoliosis can progress after you're an adult. So a lot of times people say, okay, well, I'm skeletally mature, it's not going to progress anymore, and that's just not true, particularly if the curve was greater than 30 degrees when you reach the end of puberty. And the other things that can affect that are, so let's say that you have a scoliosis and then you enter menopause and then you get arthritis and then joint shift, and that can cause the curve to change more, and then that can lead to narrowing of the spinal canal, can lead to narrowing of the holes where the nerves come out. And so I think it's really important that if you had a curve to start out with, that you if you were ever given exercises for that, either through Scully Smart or one of the other programs, or even if you were given it through a therapist, continue to do those. And most of the time they'll tell you that, continue to do these exercises, but they're kind of boring and they don't really take long, but they're kind of boring. And so people stop doing them. Continually work on your posture. I mean, I think that's something that we can all, do and benefit from. And then surveillance. So for my patients with these conditions, I typically will get x-rays every 6 to 12 months, depending upon the circumstances. And then work with psychological health professionals to handle things like stress and anxiety in a more optimal manner. Part of that is to give you the time to do the exercise that you need to do. We're all very busy, lots of work, other things to do, but that has to become part of it.
So I know you briefly mentioned, having the full team of your OBGYN, of your primary care doctor, of Ortho South if you need it. But what role or how often should you see them? 'Cause I feel like I've seen a lot of patients that may not even have like a primary care doctor.
Yeah, I do too. And it's something that I tend to disagree with greatly. I mean, we kind of are kind of a specialty society, but I always think of the primary care doctor as the quarterback. They can help direct things. They help get those general labs done. They help keep things on track. And so the general rule, and it's also an insurance where you should see your primary care doctor once a year, at least every 18 months, but really once a year. Is when you should see them. And in terms of the other physicians, and during certain parts of a woman's life, the OBGYN doctor will serve that role. But the other doctors, for instance, the endocrinologist, others, we're not your primary care doctor. So you need someone who is monitoring your labs, who is just monitoring you in general.
I like that, the quarterback, the center. Yeah, I like that. All right, so moving on. Let's pull up these slides. Give me just a second. All right. How do we address women's spine issues here at Ortho South, the Spine Institute?
There are several things that we do that I think are really important. Number one, we do have an awareness of all of these issues. So we know the things that women are more prone to, and we know the things to look at with you, and we know the things to try to help you address, even if we don't address all those issues. So, I mean, I don't frequently, although sometimes I do if a person does not have a primary care doctor or they're having trouble getting one, I will go ahead and order a bone density test or vitamin D levels or that sort of thing, but that's really not the primary job. But we're aware of that those things need to be done, and sometimes go ahead and do them, for the person. We do a targeted, a detailed history and exam, and we do other diagnostics, x-rays, MRIs, CT scans, bone density studies. All of that's for an eye toward how everything fits together. We prescribe physical therapy with specificity to address those issues. So some of the issues are issues that one may have had, for instance, from a scoliosis that may not have really progressed, but the person's not really doing anything to address it either. And then they have back pain for perhaps another reason. All of that has to kind of fit together, and I think that it is good to address the issue that is the problem, but keep in mind the issue that can become the problem if you don't teach the person how to address it. Keep in mind that insurance carriers will sometimes not allow two different types of physical therapy to occur at the same time. So for instance, a person may have pelvic floor dysfunction and they have a disc herniation. That's physical therapy, but there are two different types of physical therapy. So sometimes a person has to take a break from one physical therapist, work with another physical therapist, and then circle back, keeping in mind that there are a certain number of therapy visits allowed per year with that insurance carrier. And so that's another way we can be helpful in terms of helping the person have a strategy. We're going to try to get to this point, maybe with this many visits, with these as our goals for this therapist, and then we're going to switch off and see this therapist for these particular goals.
Yeah, it's complicated, but I know Ortho South, we have a good way of communicating all parts to keep that in. So before we open it up to questions for the audience, thank you guys for watching and hearing all this information. Do you have any last remarks you want to share?
Well, I think it's very important that women realize that these are things that affect us many of them affect the male population as well, but these are things that affect us at a higher rate. I think it's important that we advocate for our health issues, when and where appropriate, and try to be consistent in our efforts. So you try to carve out time. I know it's a really difficult thing to do, but try to carve out time to exercise. Try to make an effort to know your spine, to know what's going on and know how to address it.
Yeah, that's good. All right, so for everyone who has any questions about the female spine, about the discussions, anything we've talked about so far, you can submit those questions. It really stood out to me the difference between flexibility, because I used to cheer, and so flexibility was stretch and stretch and stretch versus the range of motion.
Right. So I used to cheer too. So, and then my daughter cheered. So I cheered in high school and college. She cheered in college, and she is the one who taught me more about mobility. And then I started researching mobility more. So when I cheered, as you did, they taught you got to stretch, you got to stretch, you got to stretch. So I'm stretching one day, and she says, "Well, you need to do some mobility too." And I'm like, "Mobility? What is that?" And so she teaches me what they learned. So they do stretching, but they did mobility too. And then we did a mobility tape together. And then I started researching it more to figure out how things fit in. And it can be a game changer.
Yeah. I mean, stretching one way versus we don't move in one way. Our bodies don't.
You're stretching through the whole range of motion, and it also helps you develop better balance. And then you can see when you're trying to stretch through a range of motion, it activates your muscles differently, and you can tell yourself where you're weak and where your range is different as compared to when you're just stretching. Not that stretching's not good, but I do think that mobility gives you that extra benefit.
All right. Let's turn it over to the audience. We do have one question from Miss Linda. She says, "Your opinion on dry needling for neck and shoulder pain, what is it?"
Yes, I think it can be very helpful. I think the most important thing with all of these things, dry needling has been around since the 1970s, right? So Janet Travell is the person who kind of mapped out things for that. And so it used to be that only physicians did dry needling. And then in more recent years, physical therapists have become trained and licensed to do dry needling and do an excellent job, of that. I think in all of these things, the important thing is, what is your diagnosis? What are you doing it for? What are your goals? What other things are you doing? And what's the end game?
That's good. That goes into Ms. Charlene's question of what do you think of chiropractic manipulation of the spine to help sciatica?
Yeah, so same thing. So I work with, there's several chiropractors I refer to, and there's several that refer to me. Again, what is your diagnosis? And is this a diagnosis that is amenable to chiropractic treatment or not? Many chiropractors will, take x-rays, they'll examine you, and they'll have a boundary. If things aren't better by this point, or if I see this getting worse, I'm going to go ahead and refer you out. You need a different level of workup, for this. And I think that's completely appropriate. But in general, you need to know, what is this? What exactly are we doing? What are we doing it for? What is the goal? And have I had a complete workup?
Very good. At the very beginning of this webinar, Miss Beverly mentioned that she is 74 and she wants to know what she can do to help with scoliosis in her back. I know you mentioned the exercises that they give when you're younger, but what can you do when you're older?
Well, first we need to have x-rays and know what the degree of scoliosis is. Is it a single curve scoliosis? Is it a double curve scoliosis? Is it a scoliosis that rotates on itself? So there's different kinds. And then how much degenerative change is there around that scoliosis? And so once we know that information, and then examine you. So, I have people, you have to bend in certain directions, and that's where, so I can see what your range is. So one of the things about scoliosis is it is a disease of lack of mobility. So you're going to have one part that's longer, one part that's shorter, but generally speaking, there's a decrease in mobility. So let's say that you don't really have spine pain. You just want to do better. And so in that case, there are, once you know kind of what direction the curves are in, and if you have one curve or two curves, that then a physical therapist can design a program for you that you can do at home, and you don't have to keep going. You can do that program at home. Let's say that there's pain associated with it, then that's a whole nother
Yeah, you've got to do a little more. All right, let's see. Where did I leave off? Here we are. Okay, so Miss Andrea says that she has been told that she needs a hip replacement as well as back surgery. Do you think that she should prioritize one over the other?
Generally speaking, the surgeons will help you with that, but the general rule is the hip is done first.
Okay.
And then the spine.
All right. Miss Miriam says, where can we find more information about mobility exercises?
There's several books related to it, but there also, honestly, there's some good physical therapists and good trainers who, for instance, teach this on YouTube. But I would start with, depending on your age, and some of it is by age group, but it'll start with general mobility, and some of it is for 55 plus. Some of it is for seniors, and then there's some that are for younger folks. And I would start with looking either through a class at a local facility, or again, I found several excellent ones on YouTube, but targeted towards the age range. And then I would start out with the standing mobility one, and just one that's 5 or 10 minutes standing, and see how you do with that. And then they have those that are also floor mobility. Standing mobility is often easier if you don't have great range of motion, to start out with.
So are those exercises, or do they prolong, or they get like harder and more intense, or longer or more flexible? How does that kind of work?
It can be a combination. So generally what occurs is they get to be longer, and more intense. And you have to decide what's good, what your goal is, what's good for you. So for instance, it may not be a goal of mine to do 30 minutes, of floor mobility, but it may be a goal of mine to do 5 or 10 minutes of, mobility a day, so that I can maintain, good mobility, and then do some strengthening, and then do some aerobic, so really combining a program that has those elements. You need to have some elements of mobility, you have to have some elements of cardiovascular, and you have to have some elements of strengthening. And the strengthening needs to be, you have to have some core strengthening. We all have to have it, but particularly as we get older, in general, muscle mass decreases. You have to have that in addition to, your upper and lower body strengthening.
All right, let's see. That was my question. Sorry, you guys. All right, let's see. All right, I actually have a comment saying, thank you for this question about mobility exercises. So whoever asked that also got the response of thank you. That was Miss Irma. She mentioned that. All right, that looks like all of them. Any last thoughts on women's spine health before we close?
Well, I hope that people can share this information. I hope that you can have some consistency. I hope that these are issues that you talk with your doctor, with your daughters, with your parents, with all of this, so that we can all do a bit better by it, and we want to help.
On the front side, the preventative side.
On the front side, the preventative side, and if you're already there, let's try to get you, better from a spine standpoint, but then not forget at the end of that, you still need to do these things. So if we do injections or we do surgery or that sort of thing, those other things don't fall by the wayside. We still need to circle back around and make sure that everything around that surgery that you had done, and everything around that injection and that supports that injection you have done, works together for your benefit.
Yes, yeah, I agree. All right. Well, I know you who normally see people towards the end of, not really the preventative side, but I love how you can, get them better and hope that it's over to them at that point to, continue the exercises and continue the strengthening and lifestyle adjustments. But.
And I will say that lately, it's been a really good thing. I have had people come in for preventative. You know, I'm
Mhm.
going to be getting pregnant. You know, I'm working on getting pregnant.
Oh,
I need
that's
to know
nice.
what kind of things I can do for my back now while I can still have x-rays,
Mhm.
you know, or I want to meet with a physical therapist because I have scoliosis. Let's get some images. And I send those images, in my clinic, I send those images directly to you by email to your phone,
Mhm.
you know, so that you can pull them up and look at them. So I've been very, very encouraged by that.
That's nice. That's nice. It's all about educating
Yeah,
people.
it
So
is.
that's what we're here for.
Yeah.
But thank you guys all for joining us. If next month we'll have Dr. Weaver on, and he will be doing a few myth busters about different things with the spine. That will be next month, the third Thursday at 6 p.m. as always. But if you would like to schedule an appointment with Dr. Lee-Sigler or any of our providers here at Ortho South, that information will be displayed in just a moment. So thank you all again for joining. Thank you, Dr. Sigler.
Thank you for having me.
Mhm.